بسم الله الرحمن الرحيم. محاضرة النهاردة كجزء مهم من التوبكس اللي جوه الجاسترونترولوجي كوريكولم، وهيبقى التوبك بتاعها inflammatory bowel disease. Inflammatory bowel disease in general differ from irritable bowel syndrome or infectious bowel disorders. In spite of similarity in the abbreviation, however, inflammatory bowel disease is a big entity and big topics which need more and more work. We considered the definition of inflammatory bowel disease that includes two distinct chronic idiopathic destructive inflammatory disease of the GI tract that typically started during late childhood and early adolescence. That is the common definition. However, we should know that every word from that statement show a special explanation. For example, we say that is chronic. It's not so acute, in spite its presentation sometimes in acute phase. Also, it's an idiopathic. I mean, it's not unknown, but idiopathic. We have different playing factors in inducing the disease. However, no single factor can induce it. All of the inflammatory bowel disease, especially Crohn's disease, leave what's called remnant of destruction. And this destruction, it is a sequelae. It is the end product of that inflammation, and it is a complication of that inflammation. Lastly, when I said it's typically, I mean there is a typical presentation or a typical age. Previously, we said that we have two modes of age, and change it from bimodal inflammatory bowel disease into now a trimodal. I mean, previously there is an adult and elder. However, we have now childhood or infancy IBD. We have what's called, according to the age classification, it's A1, A2, A3. A1 is a childhood and infancy. A2 is late childhood and early adolescence, and A3 that is the elder one between 50 and 80. As regarding two main types, we know that is Crohn's disease and ulcerative colitis. That is the undergraduate needs to know. However, there is two rare conditions, that is IBGU or unclassified type, or IBG indeterminate type. According to the USS incidence, Crohn's disease represents 5 in each 100,000, and UC is 15 in each 100,000. However, now in Egypt, after improving the skills for diagnosis, there is nearly rising in detection and diagnosis of IBD cases, which make us running toward the international or even the incidence and prevalence similar to somewhat outside Egypt. Previously, we considered races are playing factors, and up to now they are playing factors. For example, Jewish itself making the patient fourfold increase of IBD in non-Jewish. It's more common in whites and well-developed areas. However, when you come to the pathophysiology of IBD, you will suffer from the theory about explanation. How to think about explanation. For example, they said that is a missense in genetically predisposed patient to his in-gut flora producing immune inflammatory reaction. That is the interplaying circle. Genetic predisposed, gut flora, missense which inducing inflammatory reaction. All of this affected by what's called environmental factors, or what's called exposome. That is the exogenous factors when the patient suffer from. I mean, there's no one factor can induce IBD. Gut flora alone, no. Genetics predisposition, no. Environmental factors, no. All of these should be interplaying together to produce what's called inflammatory bowel disease. And we have different evidence. For example, as regarding immunological mechanism for tissue injury, we have that it considered IBD an immune or autoimmune disease. In spite, commonly, the antibody is not against our own cells. Commonly, it starts by antibody against the gut flora that is immune, but with some autoimmune manifestation. We found that there is enhanced lamina propria T cell activation, then T cells will express or increase expression of surface markers and producing T cell lymphokine, and itself these T cells will become an cytotoxic T cells. And this activation lead to more recruitment of effector cells like neutrophils, and the inflammation start with subsequent elaboration of destructive substances like proteases, reactive auto radicals or metabolites. And now we can know that the immune mechanism here is not started directly against the self-action. Previously, they considered TB is a triggering factor. We considered TB, especially ileocecal TB, is a mimics, is a similar in some manifestation and some factors. However, now we consider that the main factor which stimulates the T cell activation is our own gut flora. So the defect in the immune system, we considered it multifactorial, exogenous antigen, heritable or genetic propensity of mucosal immune dysregulation. Lastly, there is increased intestinal cell permeability, or what's called enhanced delivery of that antigen. For example, when they're looking for some antibodies inside the patient with IBD, they found that evidence like p-ANCA or anti-neutrophilic cytoplasmic antibody present is about 60% in patients with UC and 10% with CD and to somewhat 5% in normal. However, ASCA, which one of the antibodies present in patients with Crohn's, present in 60% of patients in Crohn's and to less than 10% in UC and about 5% in normal. All of them show a bad detection for patients with IBD. They have what's called a bad negative predictive value. I mean, in 100 patients of CG or UC, the antibody was positive. However, 40% of the patient will be lost if we are depending on that antibody in diagnosis. So we considered it in some research and some predictors for the severity and some predictor for the course, but not for diagnosis. Genetic factors, we have what's called multiple genes. Previously, since years, we're starting by 1 or 2 genes. Now we have what's called up to 13 loci, including inside 250 genes. It's big, making the patient not be a genetically treated patient. It is just predisposition. The genes play a role in inducing the disease, in selecting the type, UC or CD, in diverting which behavior, for example, in CD may be inflammatory, may be stenotic, may be fistulizing, and even can be a determining factor for predisposition for cancer in UC. And multiple genes play a role in the response to therapy. Now we are shifting to what's called environmental factor or exposome. That is some evidence from the socioeconomic study that IBD is higher in urban than rural, higher in higher socioeconomic classes. There is increased IBD among oral contraceptive users, decreased risk of UC among smokers, while Crohn's disease is an increased risk. And that is representing how the pathogenesis occurs. That is normal. The diagram in front of you, the bacteria through passing the epithelial barrier, then the antigen presenting cells and starting inflammation, T helper cell activation, and then by time there is macrophage which will produce macrophage migration inhibiting factor. Now everything after the fight become clear and the process stop. That is abnormal. But here, which was not abnormal, that is intracellular genetic predisposition producing multiple inflammatory mediators which start the inflammatory cascade and cannot stop, because all time the gut flora, when touching this antigen presenting cell, the antigen presenting cell considered is it's not our own gut flora, it is a missense. So all time gut flora in contact, all time antigen presenting cells cannot considered is normal, all time there is inflammation, and by multiple genetic predisposition maybe the inflammation start as early as possible. This chart in front of your figure, in spite of explaining how pathogenesis occur, it is main attacks for the new strategy for treatment using biologics. All biologics play now a role in stopping one of the inflammatory mediators. For example, TNF factors or TNF alpha. It's one of the cytokines or immune modulators or immune inflammatory factors, which now some biologics can stop it. So after we can know something about the H pathogenesis, we can start our thinking how to deal with on the long treatment, how to deal with the treatment. We know some pathophysiological evidence we have. So we can block these pathological inflammatory mediators to stop the process. And that is making an evidence of the patient of IBD, where the patient of the IBD, with the patient showing genetically predisposition, as we said, immune dysregulation, environmental factors, and these environmental factors now become two splits, one at gut flora and one for other environmental factors. New environmental factors now involved in our work and in our life. For example, especially which can change also the gut flora. All food with preservatives, smoking playing a role, some early use of antibiotics, lactation, especially if the baby show no full lactation duration. So early determination of lactation, early use of antibiotics, commonly used preservative in food, and smoking, all are very important playing factor as an exogenous factors or exposome which change that is in front of you. And we know now that is infection, non-steroidal, under stress playing some roles, which making at some times you think like irritable bowel syndrome because the stress play a role. But we know that in IBD, stress may activate or may super add a presentation in patient with IBD. Generally, all of this play inducing inflammation, which will attack our gut, skeleton, axial or peripheral, skin, eye, liver, kidney. Now we have systemic disease. It's not just a gut disease, it is a systemic disease. Now we are starting by Crohn's, which was described since about 19 years. It's about 1932 and early by a Jewish doctor, Dr. Crohn's. We consider Crohn's with a special criteria. It's one of the IBD. It can affect any segment of the gut, from mouth to anus. It can affect any layer, from mucosa to serosa. The third is a skipping or discontinuity. Lastly, it is granulomatous, if we found it. So, any segment, any layer from some transmural, from mucosa serosa, skip granulomatous. and every one of them is a special criteria. When looking for the segment, yes, it can be an upper GI Crohn's, small intestinal Crohn's, ileal, colonic Crohn's, anal Crohn's, any part. And when you're looking for the skip, it means it affect for about 10 centimeter, then leave the other normal, then another after 1 meter, more than 10 centimeter, 20 centimeter, then another 1 meter, 3, then and so on. And inside that 10 centimeters, we found that is patchy affections, not affecting continuity. These 10 centimeters may affect 2 centimeters severe, then 1 centimeter less than 2 centimeters. That making you during your diagnosis, especially during endoscopy, you have to get more and more biopsies. And according to its affection of the layer, if affecting the mucosa, it produces what's called inflammatory Crohn's, one of the phenotypes. And if affect musculosa, it ends by fibrosis and commonly leaving what's stricturing Crohn's disease. And once it becomes to the serosa, now it's an adhesive outside and will induce what's called fistulizing type. I mean, there is now continuity between the gut lumen and outside, maybe to the skin. It's enterocutaneous, maybe enterointernal between small intestine loops, between enterocolonic and enterovesical with the urinary bladder and enterovaginal. And we, in our life now, and in our patient now, we are suffer from all these presentation are present previously not. When we are at young age, I think it's really to find this type. I think not so early, but or not so less to see this type. No, there is late diagnosis, misdiagnosis. It can be diagnosed like anything else, but now we consider it when we find it and getting the biopsy that the patient suffering from Crohn's, and we have all these types of Crohn's. Previously, we said about age classification, and now we said about behavior classification, and looking for about the third type of classification. We will say the location classification. That is a behavior, age, location classification. When you're taking biopsy, you find that is skip or patchiness of inflammation, transmural from mucosa to serosa, and if you find the granuloma, you are lucky because it represents only in about 20 to 25% in the best papers finding. However, its absence doesn't exclude the disease. Clinically, the patient with Crohn's disease characterized by remission and relapse. And as we said, we have 3 behaviors: inflammatory type, fibrostenotic type presenting by intestinal obstruction, or fistulizing type according to the fistulate presence. For example, we will say according to the presence, we will find the complaint. Classic symptoms commonly according to the most commonly affected area, but right lower colic abdomen with pain, one of the imminent presentation of the commonest presentation, considering sometimes the surgeons pass to surgery at appendicitis. And by the time the patient represents that is not appendicitis, it's a classic Crohn's disease, especially if associated with diarrhea. We sometimes see that the Crohn's is a pain diarrhea syndrome. Commonly low-grade fever, but once the high-grade fever presented, you have to look for the abscess secondary infection. Hematochezia is not the main criteria of Crohn's in complaint, except in chronic Crohn's. It's more. When you're looking for examination, you find the following: tenderness all over the abdomen, especially right iliac zone. May you find palpable mass if there is thickening, adherent tube, or abscess. When each patient of Crohn's or suspected Crohn's, perianal examination should be done for abscess, fistula, prolapse, fissures, and elsewhere. Sometimes you will add according to the phenotype. Inflammatory type commonly presented by malabsorption and weight loss, fibrostenotic partial intestinal obstruction with vomiting, clotting. Once fistula occur, it may be to the skin. You will find stool pass through the skin, but may even into the urinary bladder, and here the patient presents with pneumaturia and UTI, and sometimes you will find the fistula to the vagina, and now the patient passing stool per vagina, and maybe to the gut, to the peritoneum, producing what's called location or collection or abscess inside the abdomen. So we considered the Crohn's is a benign inflammatory disease, but it behaves like a malignancy, making it a bad socioeconomic impact on our patient. We have patients suffering for a long term and they cannot maintain their normal life, cannot marry, cannot deliver, or cannot get babies, and so on. So we consider the IBD now is one of the biggest, even it's the biggest entity in our gut department or all over the world. It has its own society, its own caregivers, helpers, drugs. We know that inside the GI, IBD, malignancy now are the big playing entities in our life. We work more and more hard inside them to know some about the etiopathogenesis and how to discover the medication, how to help the patient. We are sufferers. As we said, after depending on this 4R, you have to put a differential diagnosis for inflammatory bowel disease. For example, irritable bowel syndrome, infectious bowel disorder, drug-induced ischemic, and microscopic colitis. Now, you should know, we do, for example, in Crohn's, a very stressful steps for diagnosis to getting this. That is, getting the patient at which age, where is the location, what is the behavior, and especially in childhood and infancy, we consider that the growth retardation one of the commonest presentation, and for a long time this patient was treated as infections, as some metabolic disorders, some maldigestion, and by the time when they cannot grow well, the doctor review himself and do a lot of work, and they find them as what's called growth retardation induced Crohn's disease. For the first, you may suggest that laboratory investigations are essential. Yes, they are essential. Beyond the clinicals, you considered 1R. Not a mean for diagnosis. I mean, alone, we cannot set the patient suffering from Crohn's, even if he had evidence like this: leukocytosis, thrombocytosis, anemia, increased CRP or ESR, hypoalbuminemia, B12 deficiency, some serology, as we said, some specific stool tests, especially fecal calprotectin, may help you to suggest a diagnosis of IBD and suggest a diagnosis of Crohn's. But you cannot depend on them as the final diagnosis. Never to prescribe the patient any medication of Crohn's or IBD on this stigmata only. They better help you in early detection, but they will be a play makers in follow-up, especially the triple of CRP, fecal calprotectin. That is two important lab investigation. You need them to follow up. And sometimes you may get other stigmata in clinical and investigation, but by long time you will not depend on them for even follow-up. For example, hypoalbuminemia. If present, especially in UC, it's a very risky factor. For example, if you depend on serology, presence of ASCA, not a surest diagnosis. We have two antibody against ASCA. If you can get one, you say that ASCA1 positive, both double ASCA positive. And we consider the ASCA as a pre-detectors for ileal affection of Crohn's, for response for biology, and there may be the need for surgery, and commonly they are positive in ileal disease. So it's maybe some stratification for that patient using this. But when you depend on calprotectin or CRP, it's very evident inflammatory. And now, after diagnosis, you will depend on them because they are correlated well to somewhat with that disease. The second arm was the radiology. Previously, they depend on the barium follow-through. Now, are not so good. We are not depending on it, except if we suggest narrowing because it can be presented in some cases, skip lesions, but go back to the barium enema. Now, it is not so dependable. All of them are replaced by using multi-slice CT enterocolonography or MSCT enterocolonography for diagnosis and for complication like fistula or abscess. Plain X-ray is still used in rare cases needed, like suggestion of intestinal obstruction in CG or toxic megacolon in UC. I think depend now on CT enterocolonography. However, the new emerging data about MRI enterocolonography is superior to CT. But in some zones there is no MRI and they have CT, you can do it, but not a triphasic CT. It's CT enterocolonography for the small intestine and the gut, especially at high, what's called cuts, not at 8 cuts or 16 cuts. We need 64 cut CT at least to get good data. That is the radiological difference between Crohn's disease and UC. We depend on the distribution, presence of ulceration, fissure, stricture, and ileal involvement. Looking for the Crohn's. Discontinuity, segmented. Commonly, fissures, yes. Stricture, yes. Ileal involvement, it's common, and nodular, narrowed, or even ulcerated. Endoscopy is still the gold standard for diagnosis. How come? If you're looking for the CG, we find the ileal, cecal, and ileocolonic, and anal, and anorectal. All these areas are affected in more than 70% of the patient of Crohn's disease. Now, ileocolonoscopy pass through 70% of area involved, and you can get finding and you get biopsy. Already now you have a gold standard. And some new endoscopy like enteroscopy or small intestinal endoscopy or capsule endoscopy in some cases, upper GI endoscopy, all of this can help you in upper GI. Looking for the diagnosis using enterocolonoscopy, there is special precautions. You have to enter the ileum. You have to enter the ileum. You have to enter the ileum. More than 50% of Crohn's in that zone. Epidemiologist is a man who can get success to pass inside the ileum in more than 90% of cases, or even 95. He will get the following. Number one, evidence like abscess ulcer, lineal ulcer, capillary stoning, and you will find in some cases rectal spleen. And when you find the lesions, you have to get biopsy. So you have endoscopy and you have biopsy. And there is the third precautions is to get biopsy from diseased and non-diseased zone. Because when you're looking sometimes in some mild erythema and you get biopsy from that zone, the doctor said to you that the patient is a Crohn's disease, in spite you get a biopsy from erythematous area. So you have to get from diseased and non-diseased zone to fulfill the criteria of skip also. And there is big difference in endoscopic finding of Crohn's. Friability is not so common. Abscess and linear ulcer common. Capillary stoning common. Pseudopolyps less common. Rectal involvement fairly common. For UC, friability the criteria of diagnosis. There is no abscess. It's very superficial and continuous ulcers. Capillary stoning common. Pseudopolyps common. All of this. And looking for that is the Crohn's, showing capillary stoning down to the left, multiple abscess or even aphthoid ulcers. And to the right down, you look a linear, deep ulcers with long sides. This is the UC, starting by erythema friability, then superficial ulceration, loss of history, loss of chronic vascular pattern, ulceration, and in between you will find what's called the pseudopolyps. So, big difference between that. It's a chronic disease, meaning when you get the biopsy, you will get the difference. For Crohn's, rectal sparing, escape, mucinous retention, histiocyte aggregation, focal mucosal injury, granuloma, as we said, its presence is about 15, 20, 25 in the best papers. So never depend on diagnosis of Crohn's when you find granuloma only. It's a very bad behavior. Pathologist now can stratify the type of cell and say the patient showing consistent, highly susceptible, can coincide with and anal involvement in Crohn's commonly affection. Differential diagnosis commonly, you see pelvic diseases like appendicitis, cecal diverticulitis, pelvic inflammatory disease, CMV, ileocecal TB, ectopic pregnancy, vasculitis, lymphoma. And common complication with that, abscess, fistula, stricture, perianal abscess, nutritional deficiency in inflammatory type, small intestine. We consider that Crohn's disease is the commonest mucosal disease producing malabsorption malnutrition syndrome and can ending by oxalate stone. And when you're looking, for example, in cancer step or cancer percent of occurrence inside the patient of Crohn's, previously we said that the Crohn's colitis is considered, as you see, as a risk factor for malignancy. Just 3 years ago, small intestinal adenocarcinoma become evidence in patient of Crohn's. In spite the previous talks that small intestinal Crohn's is not a pre-malignant phase. Now we consider in some cases about malignancy. When you're looking for the treatment, that the old and the even now we can use it in some cases. That is step-up approach. We're starting according to the mild, moderate, severe cases using special medication according to how to think and add on by time. However, we have to some risky patients that we cannot pass through this step up or current approach. No, we can use what's called not a classic top down, but early step up. Early step up, I mean, I'm not waiting for that patient for a long time, more than 6 months, to shift them from oral to biologics, for example, from conventional to biologics, especially in fistulizing type, very extensive type, young patient, long area of affection, smoking patient. All of them we consider the patient risk stratification factors, which sometimes need early shift from conventional to biologics. However, looking for the conventional, one of the anti-inflammatory for the gut, the 5-ASA, 5-aminosalicylic acid. Previously, we use what's called sulfasalazine, that's a mix between ASA and the sulfa, and up till now they use them. However, by time we remove the sulfa and maintain 5-ASA, that is the mesalamine. The 5-ASA acting against bacteria by inhibiting interleukin-1 production and auto-free radical scavenger. So previously at 60s, they said that the sulfa play a role because it's antibiotics, and consider that Crohn's as an inflammation of the bacteria or gut flora, bacteria, and depend on sulfa. But now we consider sulfa as a side effect producing factor. It's not a treatable factor. Okay. However, still sulfasalazine present in the market and can be used. However, you can use any one of sulfa-free mesalamine, that is a 5-ASA, in dose for induction and dose for maintenance. However, up to 6 years ago, this medication play a good data for treating Crohn's disease. Now, 5-ASA is not a medication for Crohn's disease except in Crohn's colitis. I mean that the 5-ASA play a role in the colonic disease. So it will be maintained in treatment you see for induction and remission, but not now for CG, except for CG Crohn's colitis, especially when suffering from axial skeleton presentation. Corticosteroid, it is a master immune suppressive drug. It inhibits the T cell function, it inhibits phagocytosis, chemotaxis, inhibits everything. So you can get mastering of immune suppression, but you'll get more and more side effects. That's making the patient is corticosteroid side effect tolerability become very bad. We're starting by high dose for induction, and then we pass to what's called withdrawal. And when you're using corticosteroids in Crohn's disease or even IBD, you have to induct and withdraw within 3 months, not more. More than 3 months, the patient will suffer from side effects. So in Crohn's disease, you will use it for induction, but not for maintenance. And when you're using corticosteroid as a systemic treating material, you have to explain the patient the side effect, and you have to explain the patient how withdraw, and have used the patient between 40-60 milligram per day. And now gradual tapering is a must. Otherwise, you will suffering from weight gain, hypertension, diabetes, infection, osteoporosis, more and more side effects. And when you give the patient steroid, the patient will be passed in one of three. Steroid responder, when you stop, the patient maintain good. Steroid dependent, when you get up to 20 milligram, you cannot withdraw no more, otherwise the symptoms will recur. And steroid refractory, when you're using the full dose, the patient no response. The problem in steroid refractory and steroid dependent, that should shift from that medication to the new biologics. We consider that the biologics is very important for us to treat these patients, because since years ago we are suffering from how we will do for that patient up to the 2000, the year of 2000. We have no more medication except corticosteroid, 5-ASA immune modulators, and by year and the evolving of using biologics, we have now a new shift paradigm from treating the patient by steroid, especially steroid dependent or steroid refractory, to shift to what's called biologics. And by some area we cannot use biologics, we have to use locally acting corticosteroids, that's budesonide. It's very good with a response about 17-30%. No systemic side effect, but also shouldn't maintain more than 3 months. You have to withdraw. After that, the patient may be suffer more, may be dependent, and you have to shift. Immune modulators, that is the third conventional. That is like azathioprine, 6-mercaptopurine, methotrexate, cyclosporins. All of this can be used in IBD. However, you have to look for the patient for the liver function, CBC, renal function, because all of this medication have somewhat some side effect on that systems. The biologics, that is the involved, that is the cytokine blockers. You have different type. Anti-TNF is the first, anti-TNF alpha, that is Remicade, that is the first one. We use it in severe cases. We use it in failed conventional and steroid dependent or steroid failure. I mean that the patient will fail to steroid immune modulators, and commonly we occur, especially this medication showing established response for induction and the maintenance together, it's about 25-30%. I mean 70% of the patient may not respond well or even showing good remission in using steroid for induction and 5-ASA for maintenance. You should know that the anti-TNF is first one using Remicade 5 mg per kilogram body weight, especially by induction 0 to 6 weeks, then maintain every 8 weeks one dose. Common side effects, you have to know that is allergy is very important, especially antibody formation and the flaring TB. We have a rare side effects like cardiovascular side effect and heart side effect, some brain effects, some infection process. All of these are side effects of using anti-TNF alpha or TNF blockers. Or biologic listed in front of you. Infliximab, that is the Remicade for UC and CD, adalimumab, anti-TNF for UC and CD, certolizumab, anti-TNF for CD, golimumab, anti-TNF for UC. And now shifting what's called for new groups, that is anti-integrin, alpha 4 beta 7, that is most valid now, that is Entyvio or vedolizumab for CD and UC, and natalizumab is not used. Then shifting more and more toward new and new interleukin blocker, interleukin 20, 23, 12 blockers for UC and CD, that is ustekinumab or Stelara. And rocatinlimab, that is interleukin 13 blocker. It will be passed to the market soon. We have a lot of biologics which may be used. And by time we will get more and more biologics, we call it non-biologic but small molecule blockers like tofacitinib or UPA. Antibiotics still play a role in some cases, especially fistulizing chronic idiochronic metronidazole or even Cipro group. Nutrition, especially in patients with fistula, you have to stop oral feeding for some times. You have to stop feeding for fibrostenotic type until the patient pass or even past operation. The patient suffering from malnutrition, never forget that the B12, calcium, magnesium are essential, even the zinc are needed. Treating complication of CD, if they're showing abscess with perforation, surgery is a must, but never forget antibiotic is an essential. And if you get abscess, you have to do ultrasound drainage, antibiotic use before any operative intervention. Fistula now biologic is a must, especially Remicade, that is the FDA approved drug for treatment fistulizing CD. Fibrostenotic, you have to pass conservative first, and rarely you need surgery if the patient not responds for this conservative therapy. Perianal disease, you should know that is antibiotics, corticosteroids, 6-mercaptopurine, surgery, all are needed. All of them should be in a weaning against use of Remicade, which produce very good response for this disease. You see, it is a disease of the colon, mainly presenting by bloody diarrhea, that is making it early for diagnosis, because the patient runs to the doctor rapidly, he's suffering from blood, so he runs, so maybe an early. However, in tropical area like us, the doctor becoming delay and reluctant. He says that maybe microbial, maybe entamoeba, maybe be different before he think about it. You see, now the depend on the bloody diarrhea, you have to shift for especially early investigation, and when you find them positive, you have to shift for early endoscopy, because endoscopy and the biopsy still the gold standard. When you're looking for the colon, you will find the erythema, edema. It starts by involvement of the rectum, then ascent. So, rectum, sigmoid, left side colon, and maybe beyond splenic flexure, passing to the right side when the patient said it's pancreatitis. And sometimes stop at that zone, at rectum, at sigmoid, at left side, and you will find what's called line of demarcation between the affected and unaffected area. And the patient with UC, common UC, inflammatory polyps or pseudopolyps, loss of history, flat appearance. In extremely ill patient, you will find the patient said he's suffering from toxic megacolon, a very bad condition, toxic megacolon, which may rupture at any time. So if you have a patient susceptibility to be a UC patient or a UC patient, you find the patient look in diagnosis as toxic megacolon, no endoscopy, no barium enema. You will do in iatrogenic perforation. And when you get biopsy from UC, you will find crypt abscess with neutrophils affecting the lamina propria. Inflammatory process doesn't disrupt muscularis because, as we said, it's a superficial disease. So you see, it's not a disease of stricturing, and even not a disease of fistula common. And Rarely now you find sometimes stricture benign. However, when you find this stricture in UC, you consider it malignancy till proof otherwise. It's not classically a stricture. The patient commonly with a dysentery and may be presented according to more and more area of involvement. Pancreatitis in 30%, that is now considered pancreatitis beyond the splenic fracture presentation. You will find in endoscopy, you see beyond the splenic fracture, but maybe proctitis, proctosigmoiditis, left-sided colitis. Commonly, fever, tenderness, anemia, and albumin decrease. We considered one of the risk factors is the hypoalbuminemia. Sometimes the patient presented with diarrhea only or blood only. All IBD can presented even pre, during, or post their presentation by extracolonic manifestation. That is important. And when you're looking for UC Montreal classification of UC according to the extent, as we said, proctitis, proctosigmoiditis, left-sided colitis, extensive colitis, that is the E or extent classification, and according to the severity from S0 to S3. Never forget that is S3 is 6 blood diarrhea per day. It's common. Tachycardia, it's common. Low-grade fever, it's common. Hemoglobin less than 10 grams, it's common. ESR high, common. So never forget, when you find the patient with severe UC in that category, the patient should not treat it in his house, at his home. No, it should be treated at hospital. It's a patient to be admitted to hospital, severe UC. Otherwise, he will pass into what's called ASCUC, that acute severe ulcerative colitis, which is a very bad condition with a high mortality rate. You will find the patient with that complication, toxic megacolon, as we said, depending on the presence of fever, tachycardia, abdominal distension, peritonitis, and the colon show a dilatation more than 9 centimeters. When you're looking for the colon X-ray with a leukocytosis, but no barium-enema, no colonoscopy. Perforation is the common, especially in severe or fulminant type. Stricture is uncommon. You have to suspect the malignancy. Massive hemorrhage is common and can be ended by colectomy. Cancer, you consider the patient with UC is a precancerous condition, especially according to the duration, which will be duplicated every 10 years. According to the extensive, and colitis is more. And once you find dysplasia, sometimes is that indication for total colectomy. Now we talk in some cases about colectomy, that is, UC may be treated by colectomy, yes. But you should know that the patient with UC, when treated by colectomy, it means end of colonic symptom, but not the end of extracolonic symptoms. By sometimes he may suffer from two things: extracolonic manifestation or pouch complication, because the main line of therapy, if you use a surgery, is total colectomy with ileal pouch. You will suffer later on from pouch problem. When you're looking for the malignancy, as we said, UC and CG can be equal, especially in Crohn's colitis. However, CG now is a small intestinal adenocarcinoma, and you never know, you will never forget that some medication when be used for long term may be predisposed for malignancy, like immune modulator and so on, lymphoma. And also according to the disease duration, every 10 years, the application of the percent of care. At the first, it's about 5 to 10%. Then at the 20 years, it's about 20%. At 30 years, it's 40%. At 40 years, it's 80%. So if you diagnose patient with UC at the early age of 6 years, at the age of 50, the patient, when you do endoscopy, you will get about 80% or less minimum cancer when you go inside. You have to change all of this when you find special risk factors like anatomic extent, duration, age, PSC, which are very bad criteria. When you find the patient of IBD or UC, you have to look for two malignancy: colonic malignancy or CBG malignancy, cholangiocarcinoma. Disease activity playing a factor. Patient with risk factor of cancer colon. All of this can change the incidence rate. That is the carcinogens in IBD. You have to look for the big difference between UC and CD, and never forget the anal disease, the fistula, the abscess, the strictures, the rectal, the ileal, the inflammation, the granuloma. You have to never forget this criteria. Come rapidly to the extraintestinal manifestation. Reactive arthropathy is an essential. You have two types, the axial type and peripheral type. and resolve with the treatment of underlying bowel activity related to the activity sometimes. Commonly in chronic environment, asymmetric and migratory sacroiliitis is a common. Ankylosing spondylitis is 30 times more common in patients with IBD. There is an overlap with the HLA-B27 positive in more than 90%. Abscess ulcers in Crohn's, hypertrophy of the gum, Crohn's ulcer, oral presentation, ocular manifestation, very significant, very important. It's scleritis or uveitis, and even episcleritis with acute severe disease, and commonly associated with the special skin manifestation that is erythema nodosum and HLA-B27 positive. Hepatobiliary evidence for you that is primary sclerosing cholangitis is a very separated entity, very significant entity, and they considered now as a special phenotype that is IBD PSCC malignancy, that is a triad affair. Pericholangitis, gallbladder stones, especially in Crohn's disease. Dermatology, erythema nodosum in Crohn's, pyoderma gangrenosum in UC. Lung manifestations now considered very important. That's primary fibrosis, IPF, can be present in that patient, and sometimes bronchiectasis. And we consider that extraintestinal manifestation as a common extraintestinal, as we said, mouse, musculoskeletal, hepatobiliary, ocular, metabolic in children like growth retardation, and by time we less common extraintestinal manifestation as more and more report. For example, blood disease shifted now from less common into uncommon, including thromboembolic manifestation, very important in our patient for UC. For example, if a patient comes for you with a bloody diarrhea and thromboembolic manifestation, you have to deal. Immune pancreatic affection, very important, now shifted into major presentation. When you treat UC, the same, commonly sulfasalazine, it's now essential, and 5-ASA, corticosteroids, and immune modulator, that is a conventional therapy, and you have to start by oral, suppository, or local figures of this treatment. For example, you have 5-ASA suppository, and you have steroid anemia. You have to use it sometimes early before systemic time, and even suppository. All of medication used, especially conventional, should be reassessed within 3 to 6 months after starting. Maybe induction only for steroid, not for maintenance, and maintenance using 5-ASA and immune modulator, especially in UC. When you go back to the CD, you have only steroid for induction, not for maintenance, and immune modulators mainly for maintenance. And according to the type of 5-ASA you use, the site of release will be arrow. Steroid, as we said, oral 3 to 4, not more than 6 weeks, then gradual withdrawal. In some cases, you may need IV steroids, especially in ASUC. Never forget, potinoids for UC and CD can be used, but never extend its use beyond also 6-8 weeks, not more than 2 weeks. Immune modulator, as we said, and biologics the same, and we have the table of biologics, which type for UC and CD, group anti-TNF, so group, second group is anti-integrins and alpha-4 beta-7 integrin, group 3 interleukin blocker, interleukin 12 and 23 blockers, interleukin 13 blockers. We have more and more. When you come to the surgery in UC, colectomy with ileal pouch, total colectomy with ileal pouch, consider. After passing through the journey of IBD, never forget that the disease activity assessment is essential from the start and follow up. For example, you have to assess the activity, then biochemical endoscopic, blood sampling, endoscopy, biopsy to get what's called invasiveness of that disease. And the main biochemical use is a CRP, calprotectin, and all of them should be used. That is the 4-arm diagnosis. That is the treatment of toxic megacolon. Stop oral feeding, hospitalization, IV fluids, IV antibiotics, starting IV corticosteroids, No improvement, patient may pass to colectomy within 48 hours. If ear diaphragm start to present or some peritoneal irritating manifestation present, surgery is a must. That is a total colectomy with ileal pouch. For long-term prevention of relapse, 5-AZA is the only drugs showing evidence, and to a little extent azathioprine. Surgery in UC, looking for the previous indication: massive hemorrhage, perforation, fulminant colitis, no response or failure of conventional therapy, steroid-dependent type dysplasia or malignancy, toxic megacolon. We get now 3 out. Fulminant colitis treated by biologics, non-respondent treated by biologics, steroid-dependent treated by biologics, and the main 4 indication is a massive hemorrhage, perforation, dysplasia or malignancy, toxic megacolon. Now we have some medication which may play a role not to develop dysplasia or malignancy when early use of biologics. They say that the main factor playing the role in induction dysplasia, inducing dysplasia or malignancy, is the persistence of inflammation. If you're starting by strong drug, especially in patient needs these biological drugs, will stop this inflammation. Now we get another one outside the risk of need for surgery, and you have to only surgery for massive hemorrhage, perforation, toxic megacolon. If you can stop the persistence of inflammation by using this medication, you can stop the development of dysplasia, malignancy, and preserve the colon for that patient. But never forget, at any time, that is a surgeon should be beside you during therapy, during treatment, during diagnosis, during assessment. At some time, said the patient should pass to surgery. Crohn's surgery, still, when you find stricture, you can do endoscopic balloon dilatation and endoscopic reconstruction. And when you need surgery at that zone, you have to less and less and less excision. You can reconstruct, right, like strictureplasty. If you find fistula, never touch the patient before biologics. You have to get the patient inside remission before touching him for surgery. And almost large type of fistula, large number of fistula, large group patients suffering from fistula respond well to biologic, especially infliximab. Masses or abscess, you have to get strong long-term antibiotics, and you can use ultrasound guided drainage, and you can use to somewhat rare surgical drainage. Intestinal obstruction, the patient failed to conservative therapy, may need early surgery, not wait to be a ruptured or perforating patient. Thank you.